Okay, we are live. All going okay? Okay, yeah. I think it's fine. Good morning, Dr. Varun, Dr. Lalita, Dr. Mahesh. Nice of you all to join us early. Is everything good on your end on YouTube? If not, if you're having any problems, please just message there so we can check it out. Everything at this end is fine. And we are all quite set to go in a little while. I know at the moment you're only seeing a video and no audio, but that music will start in a few seconds. Okay. Nandini, actually, can you turn on your audio, your mic, and say something? Let's just test everybody's audio now.
Ma'am, everything is fine on YouTube, ma'am. I'm just checking it out and everything is fine to go.
Everything is fine to go. Excellent. Yeah. Okay, cool. So today I have a slightly stiff neck, but you know, the very interesting part was that I got a message from, what is it called? From Grammarly. Apparently my typing, or rather writing, last week has been at the level of legendary. That tells me, so that explains my back pain and my neck pain. It just goes on. It's a good thing, but well, it keeps one busy. So, of course, with his years of experience as writing a lot, must be very, very used to this.
Congratulations again.
Yes. Okay. So our music has started. Is it fine there? Yes. All good. So the Pramod also has joined us. Welcome. No, I'm looking here on Zoom. Hi, Dr. Joss. Great to have you back after your trip, yes, to Africa. It was nice to have some of those pictures you sent. I'm waiting to see the rest. Morning. You must be wondering why a storytelling competition or a contest. But there are two very fundamental things that are there for every doctor and every dentist. I think one of those, the very first one, is something called primum non nocere, and or basically do no harm. First, do no harm, and the second thing, which is more new, but it is informed consent. Now, when you take a moment and think on any on any day, a dentist or someone in the dental team really has to be able to tell a story and tell it well. Because otherwise, there is no way we can make these two things work together. I mean, imagine, how do you do no harm? Well, at least mental harm, if not physical harm, where you sit a patient down on his or her very first visit to you. You have found something that needs to be done. And now, in the interest and the necessity requirement of in getting an informed consent, which requires information, you are going to first and foremost tell them that not only do they need treatment, but just everything that could possibly and imaginably go wrong with that treatment. That's what informed consent is about. So when you think about it, it's a wonder not that most of our patients don't just get up and run, or at least say, "You've got to be kidding, doc, I'm not doing this," right? And yet it doesn't really happen. How often does that happen? It doesn't happen. And that's because we are dentists, but we are essentially human, and all humans have an intuitive ability to tell stories. We can present perils while making the patient believe in the science and in our abilities to handle any outcome. And that is the way storytelling works. We are maybe the stories we tell professionally are, of course, based on facts, and which is why this storytelling contest is also based on facts. Things that have happened, things that go on in your life. The entire dental team, anyone can join. It is open to dentists, students, specialists, postgraduate students, PhD scholars, hygienists, nurses, technicians, anybody within the dental world and internationally. It's a chance to come and tell us your stories, for them to become permanent, because of course we are going to include them all into an ebook. And at the same time, everybody who does take part will get a certificate for participation. It's a new idea, but it should be fun. It's in two phases. The first phase, of course, is everybody submitting their stories in a PDF. That will be vetted by an internal group of experts. Then the top 10 chosen will get a chance to present it, and then that's where the oration comes through. We'll get a chance to present it to an international open audience and be judged by an international group of dentists, authors, and even someone from the film industry. So when you think about it, who knows, maybe in the near future, we will have, instead of a house MD, maybe we will have an house MDS, or maybe instead of a Grey's Anatomy, we will have a Wheeler's Dental Anatomy serial. It is possible. Anything is possible. So just get the information out there. It's for all dentists, and join us. It should be great. I'm just hoping that many of you will join. Now, coming, of course, to today's presentation, we are on the 68th episode on the channel, and I do hope that you are enjoying this. If you are, please hit the subscribe button, share it, and comment and tell us what are the things you like, or maybe even don't like. September, this month, is the Childhood Cancer Awareness Month. It is very sad, and one of the saddest things when we see children suffer, but it is a fact of life. They also get affected by all the cancers, by a number of cancers, although there's a difference in the way it is. This is a time to recognize the children and families affected by childhood cancers and emphasize the importance of supporting research on these devastating conditions, and of course, the importance of early diagnosis and management, which relies on us knowing those cases. We have 2 wonderful lectures on pediatric neoplasms already on the channel. And if you would like to see them, you can just look them up. They are also linked. There's a link of the playlist also given today in the description. And today also is another one on pediatric oral pathology, although it's not necessarily cancers, it's a mix of lesions, and it is brought to us by a pedodontist. The presentation is by Dr. Kanika Gupta Verma. She has chosen to tackle this very rarely covered topic, and that's an amazing thing. And it's indeed a pleasure to welcome her. And I hope that more and more of our colleagues from other channels will be joining us, from other branches will be joining us. I have actually, used my host's privilege and seen her slides. It's going to be a great presentation, that I can tell you in advance. And it's great. I really welcome her. And
you,
coming to, thank you. Yes, and today's session is being moderated by, of course, our own in-house, Dr. Nandini DB, Professor and Head Department of Oral Pathology and Microbiology, Dental College, Regional Institute of Medical Sciences, Impal, Manipur, India. She is a passionate academician with over 19 years of experience and many presentations, research with over 60 publications, and an active member in the review and editorial board of various journals. She's currently the co-editor for our own association journal, GOMFP. She has presented a talk on pediatric neoplasms, which you just saw the picture of earlier, on this channel, and of course has moderated many sessions. She is what I would call like my go-to group that supports me in this whole venture. She is an honorary member of the Oral Pathology India team and actively supports this movement to promote oral pathology.
Thank you so much for your kind introduction, ma'am. Thank you for the opportunity.
You're most welcome. It's always lovely to have you here. And of course, we have always the expert, and today's expert is extraordinary. A very warm and appreciative welcome to our expert for the session, Dr. B. Siva Pathasundaram. He's now retired and taking the time, but he has done a lot before that. He was the head and professor and head Department of Oral Pathology, former principal, Meenakshi Ammal Dental College, registrar academic, Meenakshi Academy of Higher Education and Research, that is deemed to be university. Professor Siva Pathasundaram has published 155 scientific articles, edited 3 textbooks, which includes the most popular oral pathology textbook in India, that is Schaeffer's Textbook of Oral Pathology. He is the editor-in-chief of Journal of Forensic Odontology and has been the editor of many others, a fellow of the Indian Society of Dental Research, Indian Association of Oral and Maxillofacial Pathology, and Indian Association of Forensic Odontologists. It's a great, great honor and pleasure to have you here, sir. Thank you for joining us.
Thank you, madam.
Thank you.
Now,
with these short...
Thanks for the honor.
Sorry, sir?
No, I don't know whether I am expert in pediatric oral pathology. Anyway, thanks for the honor and thanks for your kind words.
Yeah, I'm definite you are. You just, of course, this is the kind of humility we have got used to from you. Yes. So, Nandini, with that, I'm going to request you to take over and introduce our guest speaker and start the session.
Yes, ma'am. Thank you so much, ma'am. Today, we have with us Dr. Kanika Gupta Verma, who will be talking about pediatric pathology in decrypting oral neonatal lesions. Dr. Kanika Gupta Verma completed her bachelor's from Government Dental College, Amritsar, Punjab in 2005 and her master's in pediatric and preventive dentistry from Guru Nanak Dev Dental College, Sunam, Punjab in 2009. She is a fellow in scientific writing and clinical trials and has been active academician since 13 years with a keen interest in aesthetic and surgical management of children and adolescents. She is teaching both the undergraduates as well as the postgraduates in the field of child oral health care and is presently working as professor in the Department of Pediatric and Preventive Dentistry, Tirthankar Mahavir Dental College and Research Center, Muradabad, UP. She is also a life member of Indian Society of Pediatric and Preventive Dentistry and Indian Dental Association. She has delivered various lectures in various national and international conferences. She has around 65 national and international publications to her credit, has authored and contributed many chapters for various textbooks, and she has been an active reviewer and editorial board member of various national and international journals. May I now request Dr. Kanika to kindly start with her presentation. Thank you.
Thank you so much, ma'am, for introducing me on the platform of 368th episode of Oral Pathology Tuesdays. I extend my warm regards and thanks to respected Vandana ma'am for giving me this opportunity to share my views on this scientific platform. My heartiest regards to respected Dr. Shivapatha Sundaram sir and Dr. Nandini ma'am for being here and sharing this scientific session with me here today. With all your kind permission, I would like to seek the permission to start the session for today.
Yes, please go on, go on.
Thank you, ma'am. Ma'am, I hope it's visible.
Yes, it is. It is. Go on.
Okay, ma'am. Okay, ma'am. So let us start this session with a beautiful quote that life isn't about finding yourself. It is about creating yourself. So we should always take a limitation and turn it into an opportunity, and always take an opportunity and turn it into an adventure by dreaming big in life. Myself, Dr. Kanika Gupta, Professor, Department of Pediatric and Preventive Dentistry, Trithankar Mahavir Dental College and Research Institute, Moradabad. I welcome you all and wish you a lovely good morning. Henry Ford has once said, coming together is a beginning, keeping together is progress, and working together is success. So today, our session is about the team efforts of pedodontists and oral pathologists working together in decrypting the oral lesions in neonates with the keen understanding of pathological aspects in pedodontics. I'm going to cover this discussion with the understanding of the different ages and the stages in which the childhood is being classified, the different oral lesions that we commonly encountered in the neonates, then what are the various clinical and the pathological clues we get for these oral lesions for the diagnosis and their management, and the most important thing, the parental reassurances that we have to give to the parents while managing these lesions. And of course, the teamwork that will lead to the goal to success for management of such kind of lesions in the neonates. So let us start with the classification or how the neonates, how the childhood is being classified into the various age groups and the stages. So the classification of the child life into the well-defined periods has become an important standardization to determine the care and the interventions that are necessary to increase the chances of the survival of child. The childhood is classified into the periods from birth to 2 years into infancy, and this infant age group is being classified as having a major age group, that is the neonates. But the neonates are often a kind of a period that is commonly ignored by the dentist and even the parents also when it is concerned to the oral lesions. The second age group that is seen is from 3 to 8 years of age, that is classified into the early childhood period. Then from 9 to 11 years of age of children are being classified as the middle childhood age group. And the pubertal age group that is commonly known as the adolescent age group falls between 12 to 18 years of age. So today we are going to discuss about a kind of a much ignored childhood phase, the neonatal period. According to World Health Organization, a newborn or a neonate is a child who is under 4 weeks or 28 days of age. This period is considered to be the most crucial period of the child health because, as the stats reveal, the neonatal mortality rate contributes around 41.6% of the total mortality that is seen in the children who are under 5 years of age. Now, coming to the important thing, that why we are so keen to discuss about the oral health in neonates, why it is so important. According to the American Academy of Pediatric Dentistry, it has been said that the two basic age groups that include the perinatal period as well as the infant oral health, these both could be the foundation upon which we can lay down the preventive education as well as the dental health care. so as to enhance the opportunity for the little ones to have a disease-free oral environment for the lifetime. So for these, for maintaining the oral health in the neonates, we should recognize the team that can work together in the best possible ways. And this team includes, of course, the dental specialist that involve the pedodontist, oral pathologist, as well as the radiologist. Then we have the physicians, the pediatricians, the common community healthcare workers, like the Anganwadi workers that are working day and night in India, to provide an anticipatory guidance to the parents as well as the caregivers of the children, to instill the preventive strategies and the therapeutic interventions in the children. So the common term that is being used is the anticipatory guidance. Now, what is all about the anticipatory guidance? Anticipatory guidance is a guidance that we commonly provide, like the pedodontist or the dental specialist, or it is being provided by the pediatricians. So it is a guidance that is given to the parents or the child guardians, or so that they can just assess the growth and the development of their child. Moreover, we have to make the parents aware of in identifying any kind of a lump or a bump they recognize in the mouth. Lump or a bump is a kind of a layman term that we commonly says to our the neonates parents, like if they can recognize any kind of ulceration or a lesion in the patient mouth, they should immediately report to us. Then beside these lesions, there is also sometimes evidence of a tooth-like substance that is commonly the natal or a neonatal tooth. So if they found any evidence of a tooth-like substance in the mouth of a neonate, they should immediately report to the concerned dental specialist. Then beside all these, the other important aspect is maintaining the oral hygiene. Oral hygiene should be maintained not only in the child's mouth, but also in the mother's mouth, because commonly the bacterial invasion goes from the mothers to the children. Then in the anticipatory guidance, beside the dental team, the role of nurses, the Anganwadi workers, the pediatricians, and the child healthcare professionals is quite helpful. So coming on to the basis of our topic, that is the oral lesions in neonates, and what are the various clinical and the pathological clues by which these oral lesions can be identified and managed in time. There are quite many oral lesions that are being ignored in the neonates. These include the cystic lesions, the cyst, the benign and the malignant tumors, the traumatic injuries, various kinds of bacterial, viral, or fungal infections, and autoimmune lesions. Now, why it is important to diagnose and manage all these lesions? As we all know, the oral cavity is the reflection of various systemic diseases. So in newborns, these oral lesions are commonly left undiagnosed, and this happens generally because of the misconceptions that commonly prevail in our Indian society regarding any kind of a lesion that occur in the mouth of a newborn. Secondly, it is because of the lack of resources that parents commonly fail to report their children to a specialist because of the poverty or because of the limited source they have. Then thirdly, because of the limited knowledge of parents, as well as we can say the limited knowledge of the child healthcare professionals, that these lesions go underreported or misdiagnosed. Thus, the basic mantra for the diagnosis and management of such lesions is we should have and we should give the adequate knowledge, awareness among the parents as well as the child healthcare providers, as well as the dental team. And the third important aspect is the referral. So referral by the child healthcare professionals to the dental specialist, and even the referral by the dental specialist to the child healthcare providers. So discussing the lesions one by one, the cystic lesions that are commonly seen in the neonate's mouth. In our day-to-day practice, we commonly see the lesions that occur in the form of the nodules in the oral cavity of the newborns, and they are commonly confused with what type of cyst they are, because commonly we encounter 4 or 5 cysts in the patient mouth that are commonly happen with a high grade of prevalence. But commonly the people go confused and they just term it like it is abstinent pearl or it is a bone nodule. So we have to justify all these lesions either based on the histopathological part histopathological investigations, and finally correlating it with the clinical findings. So when we have the small multiple nodules commonly appearing as the white or cremission color, and they appear histopathologically as the keratin-filled true cyst, they are being confused with the gingival cyst or the abstinent poles. Now, the diagnosis and the differentiation between these two cysts is commonly determined by their clinical appearance. Like in the case of the gingival and the dental laminar cyst, as the name suggests, this cyst appear because of the remnants of the dental lamina, that is the cell rest of series, and they appear on the crest of maxillary and mandibular dental arches. So they are present just at the crest of either of the maxillary or the mandibular ridges. So the prevalence rate of this gingival or the dental laminar cyst range around 13.8%. Coming on to the abstinent pearls, or they are also known as the mid-palatal raphe cyst. These are of non-odontogenic in origin. As the name suggests, they are present on the mid-palatal raphe region at the line of the fusion between the two palatal shafts. So they happen because of the entrapped epithelial remnants between these two palatal shelves. And the prevalence rate is quite high, that is around 35.2% cases we commonly see the abstinent pearls. Then the next cyst of a common prevalence is the Bowen nodules. The Bowen nodules appear as the numerous nodules commonly seen at the area of the junctional area of hard and soft palate, or sometimes they are even present at the buccal or the lingual surfaces of the alveolar ridges. So here you can see one of my patients that is having the Bowen nodules, and they were quite arranged on the buccal ridge of the maxilla. So these histopathologically are identified as the keratin-filled cyst. Approximately the prevalence rate falls around 47.4%. Bowen nodules are said to be the derivatives of the salivary gland structures. The another cyst of origin is the eruption cyst. Eruption cyst is a result of the rare degenerative cystic changes that happen in the reduced enamel epithelium remnants of dental lamina. As the name suggests, eruption cyst is obviously over any kind of erupting tooth. So you must be confused that in the neonates, how we have erupting tooth. So in neonates, we commonly see sometimes the natal or a neonatal tooth, and overlying this natal or a neonatal tooth, sometimes the eruption cyst happen to be formed. So eruption cyst leads to the impediment of the eruption of the tooth because of the dense fibrotic mucosa that is overlying the structure of the tooth. It is commonly seen as a bluish dome-shaped translucent appearance that is a kind of a compressible swelling, and we can diagnose it by going for the fine needle aspiration biopsy. The treatment commonly include either we go for the marsupialization or simply we go for the surgical extraction along with the extraction of the associated tooth. The next cysts are the epidermoid and the dermoid cyst. These are, as the name suggests, they are the benign developmental disorders that are commonly found on the floor of the mouth or the submental region, with the prevalence rate of around 23.3%. Because of their large size, they commonly leads to disturbance in the feeding habits and the respiratory distress also. Histopathologically, they are epidermoid cysts, they are lined by the epidermis, whereas the dermoid cysts are commonly having the presence of adnexal glands. And the treatment is based on the surgical enucleation of such cyst. After the cyst, we also encounter the various kind of infections in the newborns, and these could be the bacterial infections, the viral or the fungal infections. The common infections of the occurrence are like osteomyelitis, or they could be the herpes simplex virus infection, or it could be the candidiasis that is quite common in origin. So first one is a bacterial infection, that is the osteomyelitis. Osteomyelitis is commonly seen in around 1 to 7 live births among 1,000 hospital admissions. The prevalence is quite high among the males, and especially in the preterm newborns. This could be because of obviously because of the bacterial invasion, either because of this S. aureus or E. coli bacteria, because of the prolonged hospitalization of the neonates, It can lead to the nosocomial infections of these bacteria and finally leading to the osteomyelitis. And it is because of the impaired nutritional status of the child and a prolonged ventilatory support in the ICUs. The maxilla is most commonly involved as compared to the mandible. The common clinical findings that we see with the osteomyelitis, because it is a kind of the inflammation, so inflammation of the bones. So the common features are edema, redness of cheek, conjunctivitis, nasal discharge, accompanied with a high-grade fever. Investigations include, we go for the blood cultures, ESR counts, and the leukocyte counts. Because it is a bacterial infection, so commonly it is dealt with the antimicrobial drugs, and the surgical intervention can be of the way for survival. And this osteomyelitis is commonly go alongs with the high grade of morbidity. The second infection is a viral infection that is commonly seen in the neonates, is herpes simplex viral infection, in which around one child in 3,000 or to 20,000 live births are commonly infected. Herpes simplex viral infection is commonly happen because of HSV1 virus or herpes simplex virus 1, and common origin is because of the maternal herpes infection. Sometimes the mothers are suffering from vaginal herpes infection, so that leads to the herpes in the child's mouth also. And it appears in the form of the vesicular eruptions that could be either single or in clusters, commonly ranging in the size of 1 to 3 millimeter, and they ulcerate in a few days. And investigations that we go for are the viral cultures, the PCRs, or the serological test. The treatment concern is we go for the topical application of the antiviral drugs like the acyclovir is given. The next infection that is quite commonly seen is the fungal infection, that is the candidiasis. Candidiasis is common in even 2 to 20% in the preterm newborns. Candidiasis happen because of the vertical, that means during the birth, or the vertical or the external contaminations. They happen because of the immature immune system of the newborns, because of the prolonged catheterization, because of a long hospital stay of newborns in the NICU especially. And it happened because of the Candida albicans. Many candidal species are involved. It is a kind of opportunistic infection, but 75% of cases happen because of the Candida albicans. Appearance is kind of the white plaque that is appearing over the various areas in the mouth, and tongue is commonly involved. And investigations are based on, we go for the fungal cultures, either from blood, urine, or CSF. And the appearance is of hyphae, epithelial cells, as well as the necrotic tissues. The treatment is commonly, we prescribe that you should go for the maintenance of the good oral hygiene, and finally the candidiasis will be go off. The next lesions that we see in the neonates are because of the trauma, the traumatic lesions, traumatic ulcers, traumatic injuries. So one of the traumatic injury that happened in the neonate is the mucocele. Mucocele is a kind of a cystic cavity that occur because of the alteration of the minor salivary glands due to trauma. The prevalence rate is found to be around 2.7% in less than 1 year old child. The two types of mucoceles are commonly seen, that is the extravasation and the retention mucoceles, with the extravasation mucocele being more common and reported in 88.7% of cases. It is commonly seen over the lower lip with 79% of prevalence rate, and it appears in the form of the bluish translucent fluctuant swelling. Whereas if we go for the retention mucoceles, they are of rare occurrence, and even the retention mucocele can be encountered in any area of the patient mouth. Retention mucoceles commonly contain the viscous mucous material, and we can differentiate these two mucocele with the histopathology, as the retention mucocele always have an epithelial demarcation with no inflammatory cells as compared to the extravasation mucocele. These mucoceles commonly leads to the mechanical obstruction during feeding. So the treatment intervention are going for the surgical excision of such cyst. Next traumatic lesion that is seen is the ranula. Ranula is a rare lesion that is seen and commonly seen at the floor of the mouth. It happened because of the extravasation of mucin with the prevalence rate of around 0.74%. It has quite a good similarity with the mucocele, but still the differentiation can be made with the fine needle aspiration biopsy or the histopathological assessment, or we can even go for the MRIs. In the histopathology, it shows the presence of epithelial lining, that is appearance of a true retention cyst, and the ranula is always quite bigger in size as compared to the mucocele. The treatment is often marsupialization or the surgical excision, or it can be go for before going for the marsupialization, we can have to go for the aspiration or the cryosurgery even. The next rare benign reactive mucosal disease is the Riggerfit disease. Riggerfit disease is a disease that is commonly seen associated with a natal or a neonatal tooth. As the term suggests, and you must be knowing of, the natal tooth is that tooth that appear at the time of the birth, whereas a neonatal tooth is the tooth that appear within the 1 month of the childbirth. So commonly this disease is seen in the form of an ulceration that is unifocal or multifocal in appearance, and the patient is having difficulty in getting feed because the ulcer is quite painful. And this ulcer is specifically seen in the midline of the tongue, because it is exactly at the position where the natal and the neonatal teeth are seen. So here, if you can see, this is one of my case in which I got the child with a ulceration over the ventral surface of the tongue. And this ulcer was quite a big ulcer, and it was associated with the 2 neonatal teeth in his mouth. So the treatment plan was done by the extraction of these teeth. I just go for the extraction of these teeth, and finally the ulcer got relieved within a few days. And the treatment for the ulceration is commonly either we go for the extraction, but sometimes what happens is the natal and neonatal or a neonatal tooth, whatever the ulcer is associated with, sometimes it is quite firm and we can't go for the extraction at that particular time. So we can simply go for the smoothing of that incisor ledge. So we just go for the smoothing so that the sharp margins don't get the ulceration happen. Or we can even go for the covering of the surface of the incisor ledge with some kind of a material, like go for the composite or the GIC, so that the smoothened surface can happen. Autoimmune diseases are quite a rare occurrence in the neonates, but still the neonatal pemphigus vulgaris is reported in the neonates. It is a rare vesiculobullous disease that is caused because of the transplacental passage of maternal IgG autoantibodies against the DSG-D3 protein. It appears in the form of the ulceration over the skin, over the mucosal area, and even the mucocutaneous areas soon after the birth. These kind of the lesions commonly resolve within 2 to 3 weeks of the childbirth. Histopathologically, there is quite a specific appearance that acantholysis is seen in the lower spinous cell layers, with the basal layer of the cells are being attached to the connective tissue and the suprabasal cleft. Next are the tumors. So we have many cases that are being reported in the literature of the benign tumors and few malignant tumors that are being reported. So there are the reports of the benign neoplasm in the neonates, then the various teratomas, oral choristomas, the salivary gland neoplasm, and few of the malignant neoplasms that are also seen in the neonates. Coming on to the benign tumors. So what benign tumors are commonly observed in the neonates are hemangiomas, lymphangiomas, then neuroectodermal tumor of infancy, the Langerhans cell histiocytosis, and the congenital lipidus. So we will be discussing each tumor one by one. So the most common pediatric vascular benign neoplasm that occur with the prevalence rate of around 2 to 3%, having a female predilection of around 3 or 5:1 ratio. It commonly involves the head and neck region with the 60% of the prevalence rate, in which the lips, buccal mucosa, tongue, and rarely it can involve the palate and uvula. It appears in the form of rapidly growing macule that is followed by the spotted pigments when it regress. The interventions that we go for are the investigations that we go for are the color Doppler or color Doppler ultrasounds, MRIs, fine needle aspiration cytology, histopathology to identify the exact lesion. Then the treatment is based on prescription of corticosteroids, and the lasers are used to surgically tackle the lesion. The next benign tumor is the lymphangioma. Lymphangiomas, as the name suggests, the benign tumors of the lymphatic channels, and commonly seen at around 50% at the birth, with 1 to 3 children being defective in 10,000 live births. They affect both the genders. 75% of prevalence rate is seen in head and neck, involving tongue, lips, buccal mucosa, soft palate, as well as the floor of the mouth. Lymphangioma can have the two kind of appearance. They either appear in the form of the bluish black appearance, or they could be in the form of the red hemorrhagic elevated nodules. Like here you can see the whole tongue is being covered by the hemorrhagic nodules that is evenly distributed over the tongue. So they happen because of the ectopic deposition of the lymphatic tissue, as well as the congenital obstruction of the lymphatic channel, or they happen because of the vascular endothelial growth factor 2 or 3. The investigations that we go for are, because it is a kind of a soft tissue lesion, so we go for the color Doppler, CT scan or MRI. Then we can go for the histopathology, immunohistochemistry for checking the with the lymphatic markers. The treatment is based on prescription of corticosteroids. Electrocautery or cryotherapy can be done, or the surgical excisions are done for these kind of the benign tumors. Langerhans cell histiocytosis are the group of the white disorders that share the histiocyte as a common cell of origin. They are of rare occurrence, with just one case, one live birth reporting case in 2 lakh of the children under 15 years of age. A variant of Langerhans cell histiocytosis that is seen in the newborn is known as the reticulohistiocytosis, that is commonly seen at the birth. It appears in the form of the multiple petechial lesions, with the lytic bony lesions commonly seen in the posterior area of mandible, accompanied with the pain, the swelling in the gingiva due to accumulation of the multiple Langerhans cells. And the histopathology is the key for identification of such kind of lesions. The treatment is based on chemotherapy, radiotherapy, or the surgical intervention is helpful. A rare benign tumor that is seen with the female predilection of around 8 or 10:1 ratio is the congenital epulis of newborn. The congenital epulis of newborn is commonly seen in the maxilla as compared to the mandible, and it involves the alveolar ridge near the canine region. It appears in the form of the lobular or ovoid, sessile or pedunculated swelling that is commonly covered by a smooth, normal, or it could be a reddish mucosal surface. As again, it is a soft involvement, soft lesion. So the investigations are ultrasounds, CT, MRI can be done, and the histopathology is done. Now, congenital epulis of newborn is having some differential features, because itself this kind of a tumor, this kind of a benign tumor of congenital epulis occur in the neonates. So it's commonly termed as the congenital epulis of newborn. Moreover, it has some scattered odontogenic epithelium. It has lack of interstitial cells, and with the angulate body, and with more elaborated vasculature. So a lot of vasculature is seen such kind of the tumor. Treatment is the surgical excision of this congenital epulis of newborn. The next is a rare pigmented benign neoplasm that is seen among the children that are aged below 6 months of age, with the male predilection. It originates from the neural crest cells and known as a melanotic neuroectodermal tumor. It has the 2 cells that are commonly seen of origin, that are the melanotic cells and the neural cells. The craniofacial region is involved in cases of the 92.8%, with the oral cavity involvement having the tongue, palate, buccal mucosa, and the floor of mouth that are commonly involved. It appears in the form of the painless, non-ulcerative, expansile, rapidly growing, pigmented, locally aggressive kind of a behavior that is seen. So commonly this kind of a tumor just grow on. like it has an expansile growth, and it never ulcerate. It rarely it go for a ulceration. And investigations that are helpful in such kind of diagnosis of such kind of these tumors are the CT MRI. Histopathologically, we have the specific features of appearance of a biphasic tumor, obviously because its origin is from the two cells, that is from the for the melanotic cells and the neural cells. So it comprises of the neuroblast like round cells as well as the melanotic cells. So the treatment is accompanied with the chemotherapy or the radiotherapy and the surgical excision of such tumors. Epigenethus is a common teratoma that is seen in the neonate, but it is the rare in origin in the neonate. It appears attached to the base of the skull, like it could be attached with the hard palate or the mandible. The female predilection is more, with the 3 times more prevalence as compared to the males. It appears rarely as 1 in 2 lakh of the live births of the neonates. It is commonly derived from the pleuropatron cells of any kind of the germ layer. Any of the 3 germ layers can be involved. It happens to appear in the form of the unidirectional growth that is protruding from the oral cavity. Because it is highly expansile and the growth is protruding from the oral cavity, it is just a kind of a rare intracanine, having a rare intracranial extension. But because of its so expansile growth, it sometimes be associated with the cleft palate or bifid tongue or even the nose. The investigations of concern are ultrasounds or CT MRI. Because of a huge size of this teratoma, it is of poor prognosis with a high grade of mortality. Coming on to the next benign tumor, that is the oral choristomas. Oral choristomas are the kind of the tumors that are rare aberrant developmental disorders and having the male predilection, but they are histologically arising from the normal tissues. But the thing is, these tumors, they are present in the non-native location. So they are just present in not the location these normal tissues have. So commonly they are asymptomatic in origin. They appear in the form of the large masses. The common area of involvement in the head and neck is tongue, floor of mouth, or the pharynx. Oral choristomas can occur because from all these tissues like salivary glands, cartilaginous tissue. They can occur from the lingual spacious glands. They can be of gastric or the respiratory mucosal origin. They can be osseous in origin. They can arise from glial cells or the lingual thyroid areas. These oral choristomas, they commonly, because of their size, they leads to the obstruction in feeding as well as the respiration in the neonates. And investigations goes for, we have to go for the radiological investigations or the histopathological investigation. Treatment is based on the surgical excision of such kind of tumors. Coming on to the salivary gland neoplasms, those tumors that happen to arise from the salivary glands. One of the common tumor that is seen in the neonates is the xyloblastoma. Xyloblastoma, although it is a rare kind of the salivary gland tumor that occur in the neonates, it occur from the epithelial in origin. Its size vary in the dimension. It can occur from the parotid gland or it can arise from the submandibular gland. Because of its origin from the parotid gland, sometimes it even leads to the facial nerve palsy. And the treatment lies in the surgical excision of such kind of a tumor. The next salivary gland tumor is hemangioendothelioma of parotid gland. It is a benign neoplasm with the female predilection of 3 times more as compared to the males. It appears in the form of the multiple rapidly growing parotid masses that are commonly associated with the cutaneous lesion. And the investigations goes with the histopathology as well as the imaging techniques. And the treatment is based on the surgical resection. Surgical resection sometimes cause the facial nerve damage because it is linked with the parotid gland. As already discussed, rather than the benign tumor, the malignant neoplasms are quite rare in occurrence. The malignant neoplasms that are reported in the neonates, the few case reports have been reported in the oral cavity. These include the malignant melanoma, the spindle cell sarcoma, and the rhabdomyosarcoma. They occur extremely rare in the newborns. Commonly, these malignant neoplasms are seen in the head and neck areas, trunk and extremities. In the head and neck, the involvement is quite rare. And if we concern about the oral cavity, the involvement of such malignant neoplasms are even rarer. And in the oral cavity, the few cases have been reported. Rather, we can say till date, I just checked it out that only 3 cases have been reported in the oral cavity of such malignant neoplasm. And these are involving the heart, palate, or the tongue. With 1 case of malignant melanoma that is reported on the heart palate, the spindle cell sarcoma and the rhabdomyosarcoma were reported on the tongue. For these malignant neoplasms, as because they are quite invasive in nature, so the prompt diagnosis and the multimodal management is essential for the disease-free survival of the neonates. As we are discussing all these lesions that are happening in the oral cavity of the neonates, we still found that many of the lesions we see in the newborns who are preterm. The preterm, as you know, that it is the term in which the child is born before the completion of the gestation period of 9 months. So beside the lesions that we already discussed that are encountering the preterm babies, there are the few other abnormalities that are commonly seen in the preterm neonates. Like we see the crown dilacerations that are quite common, and they happen because of the endotracheal intubations that are seen at the time of birth. We also encountered the distortion of maxilla and mandible. We observed the high arch palate, then the V-shaped maxilla, even the narrow mandible. Delayed eruption of primary and the permanent dentition is quite common in the preterm birth. Then the preterm children are commonly suffering from the enamel hypoplasia or enamel opacities too. It is rightly said, becoming a parent is the moment when all the life's battle suddenly seem worth fighting for. So in case of any suffering seen in the newborn, we also need to manage their parents by assuring them that their child will be managed with the utmost care and efforts. As most of the lesions in the oral cavity are self-limiting in nature, so the parents' counseling and reassurance plays a very important role. Beside reassurance, we should give the adequate knowledge to parents as well as their caregivers to report such lesions in time to us, so that the adequate management can reduce the chances of nutritional deficiencies, inadequate use of the medications, and the misconceptions that are commonly associated with such kind of lesions that are happening in the newborns. Team, as the word suggests, it is together, everyone achieves more. So the great things can never be done by one person, but they are always done by the team of the people. So where there is a team, the success always lies there. So together, the pediodontist and oral pathologist can work as a team to identify not much common lesions that are encountered in the neonates by the clinical, histopathological, and the radiological findings, so that these lesions can be managed at the earliest by giving a good prognosis and a disease-free outcomes to our little ones. So the adequate knowledge and the team efforts are the way to precise diagnosis and the management. As alone, we can do so little, and together we can do so much for every newborn. As with every new life, a little sun of hope always rises. Thank you so much for the patient listening. The session is open for discussion.
Thank you so much, Dr. Kanika. That was indeed a very lucid presentation of overall view.
Thank you so much, ma'am. Thank you so much.
Very nicely done.
Thank you so much, ma'am.
Right now, we don't have any questions right now on the YouTube section.
Okay,
more than 40 people have been watching this on the YouTube.
Okay,
and congratulations on a very lucid presentation.
Thank you so much, ma'am.
Ma'am, I will just hand over to our Shripath Sundaram sir. So thank you, madam, for giving the opportunity to share this platform with respected sir. It was my privilege and honor. Sir, without much delay, I will hand over it to our expert of today, Dr. Shripath Sundaram sir.
Thank you very much. It was a fantastic presentation.
Thank you so much, sir.
Kanika.
Thank you, sir.
Thank you, Dr. Mandana, for giving me the opportunity to participate in this session as an expert. told you previously, the word expert is big exaggeration, but she must have used this out of lot of confidence and trusting me. Anyway, thanks for it. And frankly speaking, only after the invitation for the session, I gave a thinking on pediatric oral pathology. We rarely see rare neoplasms in the childhood in our practice, even in institutional right practice. We should not forget the saying rare things are rarer than what they are, but there are rare things. Most of the time, as a regular surgeon,
Sorry to interrupt you, sir. Your audio is not very clear, sir. Kindly just.
Is it okay now?
Yes, sir.
Better, sir. Better.
Most of the time, we restrict ourselves to dental caries and its sequelae as the dental surgeon and many times pediatric dental surgeons.
Yes, sir.
I was curious to know whether do we have any classification for pediatric oral pathology or pediatric diseases, but I could not find anything.
No, sir.
We oral pathologists have a mechanism and template for any diseases. That is developmental, inflammatory, infectious. Infectious can be bacterial, viral, or fungal, and neoplasms that may be either benign or malignant, and the miscellaneous. This miscellaneous is very important. Anything which don't find any place in the above category is made to sit here. Many a time we place metabolic, hormonal, autoimmune, and idiopathic diseases in this category. But I want to caution some of the so-called diseases which are discussed here, which are given in the literature, are not really diseases. They are only slight deviation from the normal. For example, dental lamina cyst, bones nodules, or geographic tongue, fisher tongue. They are slight deviation from normal. They are not diseases at all. And they don't need treatment also. All the patient and parent need is only reassurance. Of course, few lesions that give little discomfort to the patient, like a natal tooth, a neonatal tooth, or rigafedi disease, or ankylosing, they should be addressed. So all the lumps and bumps may not be really diseases. We should desist ourselves from being a disease monger and make the patient and the parent anxious and apprehensive. And as you said, it is the high time the pediatric dentist, oral physician, and oral pathologist sit together and formulate and evolve this as a super specialty. And thank you very much. Thanks, Dr. Mandana.
You're most welcome, sir. It is our pleasure. There's a question that I think Nandini can take.
Yes, ma'am. There's a question from Professor Joss Hille from South Africa. He says, like, very good. Have you found any pleomorphic adenoma and mucoepidermoid carcinoma affecting the neonates?
Ma'am, exactly in my term of serving this dentistry, ma'am, till now I haven't found this kind of a lesion in the neonate's mouth. Ma'am, sometimes it happened that they might be reported, but the thing is they are not being reported to the dental specialist. They are being covered either by the pediatrician, but most of the time they are not being referred to us even. Ma'am, that is the basic flaw that is between recognizing such kind of a lesion by the dental specialist. Ma'am, that's why I felt this topic is a kind of a concern that we commonly leave it, because sometimes the parents are not coming to us because they are just simply going to the pediatrician and just showing the lesion to them, but they are not being referred to the dental specialist. So that might be the reason, ma'am, because we are not finding such kind of a lesion so clearly. Ma'am, commonly the referral being done by the pediatrician is for either the rigafit disease, for the natal and neonatal teeth. They are commonly calling us. They are commonly calling for the extractions and all. But the sad part is this: the pediatricians and even the child healthcare workers, ma'am, they are not commonly referring to the pediatric specialist, especially.
Thank you so much, Dr. Kanika.
Thank you.
There's
Thank you.
one more question by Professor Joss Hille himself. He's telling, could the experts elaborate on neonatal osteomyelitis of the maxilla, especially the pathogenesis? Sir, I think it's more of question to you, sir. Expert opinion, sir.
Actually, neonatal osteomyelitis is mainly probably due to the prolonged catheterization. There is no exact cause for it. And it is also rare and rarely seen by the dentist, this neonatal osteomyelitis.
Yes, sir. Yes, sir. Ma'am, as of now, there are no more questions on the YouTube live stream, ma'am. So,
You know, the thing, what I feel actually now that what we all need to work is we have already heard that, you know, things like the whole periodontal health affect have a role in preterm birth and in the mother's health and in the neonates health. So I think we need to get ourselves, dentists need to get involved a little more there, and we need to get ourselves somehow interjected into that beginning, maybe with combining our efforts and joining some obstetricians, so that we are on call and we can start interacting with the mothers, with expecting mothers. And then that is how we will begin to be involved right from the beginning, where we can see. And there is so much, we already know that even things like caries are affected by the mother's, status of caries, her count of microbes and how active are her caries, carious lesions. So I think we really need to fight for that. So
Yeah,
I think now you can sort of begin
I have
to
one more thing to
start.
The occurrence of dental laminas is more common in neonates than described in the textbook. And it not at all require any treatment. Even rubbing with a slight more pressure will dislodge that. Not at all give, so it gives only anxiety to the parents. And another thing is neonatal or candidiasis is more common. That we should be cautious. Very recurrent candidiasis occurring in a child, we have to look for the other infectious diseases or immunosuppression. With think in terms of immunosuppression.
Ma'am, there are two more questions on the YouTube, ma'am.
Yes,
Professor
please.
Josile is telling, thank you very much for this seminar. Is pediatric dentistry being recognized as a dental specialty in India?
Yes, ma'am, of course.
Yes, very much.
Yeah. Separate, it's a separate dental branch as such, sir. Dr. Osmani from Ecuador has posted one question. A rhomboid glossitis median is seen in children. Could it be confused with ectopic thyroid gland? Dr. Kanika, could it be confused with a thyroid gland?
Ma'am, according to the position, it is a kind of a confusion, because ma'am, the location is quite similar. But the thing is, when we go for the investigations, we can definitely determine at what kind of the sources and what kind of investigations are going to help us in the identification of these two lesions separately.
Dr. Nandini,
Your comment?
median rhomboid glottis will be divide of papilla, that is a flat lesion. And usually the lingual thread will be slightly elevated, and most of them is lobulated. That occurs right posterior to the normal site of occurrence of the median rhomboid glossitis.
Okay, sir.
Thank you, sir. Thank you so much, sir.
Thank you, sir.
It was a very comprehensive presentation, and I'm sure that the participants today would have benefited about the most common diseases. Of course, neonatal pathology is so vast that everything cannot be covered here together. So we have so much of hard tissue pathology like the odontogenic lesions and the inflammatory lesions like noma, and we also have your fibro-osseous lesions affecting and so on. And we also have developmental disturbances. So many of developmental disturbances like cleft palate, lip, and all those things. So I hope the audience today are greatly benefited. And at the last, I would like to thank Mandana ma'am for giving me this opportunity to moderate today's session and share the screen with the respected Shivpad Sundaram sir and Dr. Kanika. Thank you so much, madam. Over to you, ma'am.
Thank you, ma'am.
You're most welcome, Nandini, and you're always there. And it's always great to have you, Dr. Kanika. That was a very interesting and very thorough presentation. Thank you for that.
Thank you so much.
And sir, thank you for your suggestions and your interaction. And I think, a good project now, maybe there is this whole, vacuum there. Maybe a book on neonatal, or maybe at least pediatric pathology is up there.
Yes, sir.
I think maybe
We'll
it can be your next project.
Yes, sir.
Actually speaking, ma'am, during my presentation also in pediatric neoplasms, I had put a classification. That classification is being modified again and again. Every time I modify it, there are new lesions getting added up. So I have done only for the neoplasms, but we can as well remake the classification as a whole. Like
Science is dynamic. That's why we got
Yes,
so
sir.
many editions of the same book.
That is what got my
The explosion, the
attention.
technology and other things make us to think further, and they subdivide the diseases
sir.
and other things.
But pediatric pathology is very interesting, sir, because their children cannot tell their symptoms. It has
Yes,
to be
ma'am.
diagnosed by the mothers and
Yes,
or the teachers or whoever is the guardian or so. So
And
that
that's
is
why, as
very
Kanika
challenging.
said, the newborn is only seen by the pediatrician first, not the
Yes.
dentist.
Yes.
We should have a protocol, something like that, to have a dental examination. It probably
Yes,
will
sir.
take 10 to 15 minutes, that's all.
Yes,
Yes.
sir.
So true, sir.
Totally, yes.
Thank you, sir. Thank you so
And
much.
so
Thank
much
you.
can happen from that. That is true. So just now it's been great. Thank you all. Now give me a minute to share all the certificates. And so Dr. Kanika dear, thank you so much. And I do hope to see you back on the channel again
Sure,
soon.
ma'am. It will be my pleasure, ma'am. And thank you so much for this opportunity. Thank you, ma'am.
You're most welcome. And sir, thank you again.
Thank you.
And you know, sir, I have this thing on the channel. I get everyone to come in as moderator, and then the next thing is that they just have to go on and present. So now
Sure.
next you will have to present soon. Thank you, sir. Thank you for
Sure,
being with
sure.
us. Nandini, here is one more for your collection.
Thank you so much, ma'am. It was an honor to share all
Most
the
welcome.
platform. Every time it is a golden opportunity. So I don't want
Thank
to miss it. Thank you,
I
ma'am.
think you can make a folder now for just these certificates.
Yes, ma'am. Yes.
Yes.
Thank you, ma'am. Thank you.
And of course, thank you all for being with us, all the viewers. Without you, nothing would work. We have had 200 people who have watched and 40 are watching concurrently. So this was a good show. If you all liked this talk by Dr. Kanika, please remember to click like so that you would get the thumbs up on the channel so we know that you liked and enjoyed this, this session. Now for the coming week, we are going to have an interesting one. It's oral pathology. We are going to have one on an oral pathology update session on the use of cytology in oral cancer. Now, I know all of us in India are going, what? But well, we have to consider it and we have to be open to new ideas, new thoughts. And we have an expert with us, Professor Jos Hille, and who's going to be presenting from South Africa. They use cytology regularly. So he is very convinced that he will be able to convince us by the end of the session that we need to do this. And the expert for the session is Professor Ravi Mehrotra. All of us know him very well. And he is an expert on the carcinoma, oral carcinoma, and of course on cytology. So with all that, it will be great and we will see you next week. Remember, I will share the details soon. If you are not getting information, please remember to join our mailing list. I have given the link in the description. Also check up our competition. It will be interesting. I'm definitely be interesting. Share it with everybody that you know it is. Remember, for anybody in the dental team from anywhere in the world. Let's hear your stories. Let's make our own collection. It will be great. And with that, I have to say thank you and see you all next week. You can connect with me all around different places. See you. Bye. Have a great week.
Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you, ma'am.
Bye, Dr. Kanika.
Bye, ma'am.
sir.
Thank you so much.
Regards, sir. Bye, sir.
Bye. Bye.
Thank you.